Sir,
we are
we
can
live
start
now.
now.
So good evening, participants. Sorry for the inconvenience caused, first of all. So now it is time to start the session on role on MYOINOSITOL in male infertility management. And today our guest speaker is Dr. Arunangshu Bhattacharya, sir. And it is my honor to introduce sir. Sir did his MBBS from Kolkata Medical College, DGO, MD, and sir is presently attached as a consultant gynecologist in Murshidabad Medical College Hospital as an EMO, and sir already worked in a ICMR project for prevention of preterm labor with Professor late Dna and Rna Metabolism sir in 1984. So with this short introduction, I request sir to take over the session, and meanwhile I request all the participants for your active participation, and please put your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with sir. So thank you, sir, and over to you, sir.
Thank you. Welcome all my colleagues for this presentation. Today's topic is MYOINOSITOL in male infertility management. We are already late because of some network problems, so I will quickly go through the initial infertility regarding male infertility. There are actually two types of infertility: primary and secondary. Primary who has never conceived, and secondary who has conceived. And male infertility refers to male's inability to cause pregnancy in a fertile female. About 15% of the couples do not achieve pregnancy within 1 year of medical treatment, and 50% of involuntary childless couple, a male infertility associated factor is found usually together with the abnormal semen parameters. Male infertility accounts for 40 to 50%. Infertility affects 7% all men, and of which normozoospermia is found in 35%, oligospermia in 35%, as asthenozoospermia 20%, and azoospermia 10%. 35% of the infertility is related to male factor problem. One is structural abnormalities, sperm production disorders, ejaculatory disturbances, and immunologic disorders. Male causes of infertility unexplained in 1/3 of cases. Varicocele is found in 17% of the cases. Immune factors in 5%, hypogonadism in 10%, undescended testes sometimes found, urogenital infection, and sexual factors. Other causes are 8%. So we classify male infertility into hypothalamic hypophysia. There is pituitary insufficiency, hyperprolactinemia, Kallmann syndrome, hyperchromatosis, pituitary tumors, and chronic illness. Testicular disorders is testicular infection, Klinefelter syndrome, testicular atrophy, Y chromosome deletion, and any systemic disorder. Seminal duct tract disorders is retrograde ejaculation and obstructive azoospermia, and there is immunological and lastly, which should be considered psychological disorder, psychosomatic cause of infertility. Precocious, what are the risk factors? Risk factors are precocious puberty, delayed puberty, exposure to toxic substances, lead, cadmium, mercury, smoking, and heavy alcohol consumption. Obesity is also a factor. Risk factors for male infertility: exposure to genitals in high temperature. The factory laborer who works in front of furnace, they are very prone to low sperm count and abnormal sperm count. Surgical injury in the vas, especially after inguinal hernia repair. Prior vasectomy, history of undescended testes, having experienced trauma in the testicles, fertility disorder, medical condition like diabetes, undergoing surgical treatment. Risk factors for male infertility broadly: thermal toxicity, radiation, and nowadays cell phone use. It is not though proved absolutely without doubt, but some say that cell phone use can alter the sperm count, particularly if we keep our cell phone in the pockets of our pants. Infection and inflammation, prostatal infection, urethral infection, epididymis, testes. Complications is social and emotional stress and relationship difficulties, expensive and involved reproductive technique, increased risk factor of testicular cancer, melanoma, colon cancer, and prostate cancer. So how do we evaluate an infertile man? Illness or injury affecting the testes. Any illness or injury, pubertal development, sexual performance, fertility exposure, occupation, and habits. Physical examination, general visualization, whether there is presence of gynecomastia, body proportion, BMI, scrotal examination, testicular size, epididymis, vas, varicocele. Now, basic first investigation done in the male is the semen analysis. And from semen analysis, if any abnormality found, then we go for the hormone measurement. The semen analysis, in semen analysis, we see semen volume, sperm concentration, motility of the sperm, morphology of the sperm, and whether any sperm antibodies. Now, as everybody knows that, every doctor knows that the term as aspermia means no semen, oligospermia means low sperm count, azoospermia no sperm, asthenospermia reduced motility, necrospermia dead or motionless spermatozoa, teratospermia spermatozoa of abnormal mortality. Usually there may be combination oligo, asthenos, teratospermia. The semen examination, first we see the volume, appearance, color, liquefaction, and viscosity, and microscopic parameter as sperm concentration, sperm motility, sperm morphology, leukocyte concentration, and agglutination. WHO criteria of 2010 says that the volume is equal or greater than 1.5 if sperm concentration is 15 million per milliliter. If total sperm count is 39 or 40 per 40, total motility is 40%, progressive motility is 32%, vitality is 60%, 58%, and morphology of normal forms 4. These are thus, we should consider this as a normal semen. And semen pH sample is primarily made up of alkaline fluid from the seminal vesicles and acidic fluid from the prostate. The pH of the two fluids combined, so that it lies between 7.2 to 8.2. As the pH is less than 7 in a semen sample may indicate an obstruction in the ejaculatory duct. Higher pH could indicate the presence of an underlying infection. The sperm functions, basic functions of the sperm is to fertilize an ovum and contribute the chromosome. Sperm functions, including their potentiality of movement, cervical mucus penetration, capacitization, zona recognition, acrosomal reactions, and sperm oocyte fusion. What are the treatment indication for the treatment of male infertility? Is extreme oligospermia, azoospermia, low volume ejaculate, and impotency. General care, reduction of the weight in obese patient, avoidance of alcohol in hypogonadotropic hypogonadism. We give HMG, FSH, dopamine agonist, pulsatile gain-rich therapy. Clomiphene citrate in hypergonadotrophic hypogonadism, and surgical treatment is done if obstruction in the vas is suspected, correction of varicocele, and vasectomy, hydrocele surgery, orchidectomy in cases of undescended testes. Impotency, if there is psychological impotency, then psychosexual treatment. For erectile dysfunction, we sometimes give tadalafil, but it also requires psychosexual management. Assisted reproductive treatment is IUI, testicular sperm extraction. If nothing can be done, then we go for this specialized. Now, the role of oxidative stress in male infertility. An updated review. Current evidence link an oxidative stress to male infertility. Reduced sperm motility, sperm DNA damage, and increased risk of recurrent abortions and genetic diseases. Oxidative stress is detrimental to fertility, pregnancy, and genetic status of the newborn. It was found that oxidative stress affects negatively in the testicular microenvironment, the aims of causing a deficient spermatogenesis damage, as well as reduced motility, altered morphology of the spermatozoa. Antioxidant treatment of an infertile man with antioxidant has received great interest in recent years. Among the antioxidant, vitamin E, C, B12, folic acid, and pentoxifylline, arginine, selenium, glutathione, L-carnitine, L-acetylcholine, coenzyme, lycopene, everything is tried. L-carnitine involved in sperm metabolism, fueling, and activities like sperm motility. The main function of L-carnitine in the epidermis is to provide energy. It may be involved for successful maturation of the sperm also. Carnitine is necessary for transport of fatty acid into mitochondria to produce energy. Low levels of N-carnitine reduces the fatty acid concentration within the mitochondria, leading to decreased sperm motility. CoQ10 is a vital antioxidant and is almost found in all body tissue, particular concentration in sperm mitochondria, and involved in cellular respiration and plays an integral part in the energy production. This contribution rationale is used in promotility and antioxidant molecule furthermore inhibits the superoxide formation. A significant negative correlation between CoQ10 levels and hydrogen peroxide has been reported, and a linear correlation between the CoQ10 levels and the seminal plasma sperm count and motility has been dissected. Selenium is also essential element involvement of the spermatogenesis. It's a major constituent of this specific group of proteins. More than 25% selenoproteins exist. Zinc also essential. These are all antioxidant. Role of DNA and RNA metabolism. It is an antioxidant, decreases production of hydrogen peroxide, zinc concentration, protective mechanism against the sperm abnormalities, including importance of treating sperm DNA fragmentation. Actually, in the semen analysis, the genetic integrity of the sperm is crucial for successful fertilization. Embryos derived from a sperm is highly fragmented. DNA have a poor result. High sperm DNA fragmentation affects blastocyst formation. Higher DNA fragmentation levels, higher the chance of failed assisted and miscarriage. Sperm DNA fragmentation is higher in subfertile men. Men with normal sperm parameters are also found to have a sperm DNA fragmentation. Management of sperm DNA fragmentation, cessation of smoking, management of obese patient, and antioxidant given vitamin C, vitamin E, folic acid, zinc, and selenium, and treatment of the underlying cause like varicocele and infection. Spermatic DNA fragmentation is evidenced by that embryo with high DNA damage is associated with early pregnancy loss. Moderately increased pregnancy chance after IVF. In ICSI, sperms are injected into the optimal environment, thus reducing the chance of laboratory-induced damage to the sperm. In IVF, copies of low levels of sperm defragmentation had LBR of 33%. Sperm DNA damage is not found in to be predictive for ICSI management. Some important ingredients useful in repairing DNA fragmentation is vitamin D3, glutathione peroxidase, superoxide disimulase, acetylexid, and CoQ10. Effect of combined effect. And lastly, we come to our today's discussion, and it is a talk of the day now that MYOINOSITOL has a great role in male infertility. What is ionosital? Actually, ionosital exists in 6 forms. Ionosital exists in 6 forms: cis, AP, allo, myo, neo, cyclo, L, choreo, D, choreo, and mucoionositol, of which this myoinositol, followed by the most diffuse form in the nature, is 1,2 cis, 1, 2, 3, 4, 5 trans, 4, 6 cyclohexanol. It is called myoinositol, followed by D-chorioionositol. The conversion of myoionositol into D-chorioionositol is accomplished by an enzyme with epimerase activity, which is responsible for their different tissue distribution. In fact, every organ or tissue has a specific ratio of Mi to DCI, fundamental for the correct ionosital and correct ionosital related function. Intestinal absorption of a high amount of myoionositol is considered safe, as highlighted by several studies that proved the absence of side effects even after ingest in large quantity. In addition, in vitro and in vivo results support that increased myoionositol intestinal absorption when combined with alpha-lactalbumin administration. Once absorbed, ionositol phosphate are metabolized into an unphosphate myoinositol by ionositol phosphatase MYNPP1 and then transported to the cytosol of the cells. Myoionositol remains strongly concentrated into the seminiferous tubule. In spermatozoa, myoionositol plays a key role as an intracellular second messenger through the regulation of calcium level. It also intervenes with the regulation of sperm motility, capacitization, and in acrosome reaction. The activation of intracellular transmission system necessarily leading to an increase in the cytoplasmic and mitochondrial calcium level. High calcium level stimulate oxidative metabolism, including the production of ATP, depending on the energy requirement. This system needs a good functional state of the mitochondria, consequently with high mitochondrial membrane potential. So myoionositol roles in the male is recently researchers provided that MMP correlates with the higher fertilizing capacity of the spermatozoa and higher spermatic motility. Several studies highlighted an interesting role of myoionositol, which proved able to increase the MMP and sperm motility. In IP3 form, myoionositol is involved in the activation of AKT, which is fundamental protein involved in the maturation of the spermatozoa. The myoionositol in the IP3 form initiate a cascade of reaction, which always leads to a phosphorylation of tyrosine, reduces and reflects the state of capacitization that makes the male gamete available to fusion of the oocyte, acrosome reaction. Myoionositol also represents a second messenger for gonadotrophin, follicle stimulation, FSH. At the testicular level, FSH plays a key role to control the Sertoli cells. Sertoli cells as a number and function, promoting the differentiation of the cell essential to sustain a normal spermatogenesis. Myoionositol acting as a second messenger regulates the activities of the FSH and thus may result in useful to counteract the alterations of the hormone level. In addition, myoionositol administration lowers LH concentration. The high FSH and LH serum concentration relates with low sperm concentration. On the other hand, MI increases the level of inhibin B, a glycoprotein, and secreted from the testes as a product of the Sertoli cell that acts as a negative feedback to regulate the FSH secretion. Actually, MYOINOSITOL and chorioinositol were given very much in the case of the polycystic ovarian syndrome, because we actually we thought before insulin interfering, we thought that the alterations of the FSH and LA interferes with the ovulation. So it has important role in polycystic ovary of female. Now, in male infertility, it also alters the FSH and LH serum concentration with low sperm, high FSH and low LA concentration relate to low sperm concentration. On the other hand, MYOINOSITOL increases the level of inhibin B, a glycoprotein secreted from the testes as a product of Sertoli cell that acts as a negative feedback for FSH. In men, either with normal or altered spermatogenesis, there is a strong inverse relation is reported between the inhibin B and FSH level. It lowers the inhibin B and improves the FSH level. Author publication. Results of in vitro studies. So it proves that MYOINOSITOL improves the sperm parameters. It's evaluated the effect of MYOINOSITOL on sperm parameter and reproductive hormones at baseline after 3 months of treatment in men with idiopathic infertility. No adverse reactions observed in for MYOINOSITOL. MYOINOSITOL also significantly increases the percentage of the acrosome reacted spermatozoa, sperm concentration, and the total count with progressive motility. In addition, MYOINOSITOL rebalances the serum luteinizing hormone, follicle stimulating hormone, and inhibin B. This clinical improvement of idiopathic infertility patient should encourage MYOINOSITOL in the treatment of these disorders. Actually, in male infertility, in 1/3 of cases, we actually found it to be idiopathic. We do not found anything except the altered semen parameters. MYOINOSITOL is a safe supplement, able to significantly rebalance serum gonadotrophin and inhibin B levels and to increase the sperm parameters in patients with idiopathic infertility. MYOINOSITOL contributed to balance the hormonal and sperm biomarker as act as a second messenger, regulating the activities of several hormones. Articles showing importance of MYOINOSITOL, the oxidative stress and myoinfertility, the beneficial effect of the ionositol on the sperm motility and mitochondrial function can be due to their many action other than antioxidant properties, insulin sensitizing properties, prokinetic activity, and hormonal regulatory effect. MYOINOSITOL plays a pivotal role in the reproductive physiology, positively influencing the development of oocyte, spermatozoa, and embryo. MYOINOSITOL induces a significant increase in the sperm motility and in oxygen consumption. The main index of oxidative phosphorylation efficiency or ATP production, both are basal and in vitro capacitated samples. Moreover, we provide evidence for a significant protective role of MYOINOSITOL against oxidative damage to DNA, thus supporting the in vitro use of MYOINOSITOL in assisted reproductive technology. MYOINOSITOL would seem to play an important role in the success of spermatozoa spermohistogenesis as well as osmoregulation. Moreover, MYOINOSITOL involved in the control of intracellular calcium. Sperm motility is sustained by the continuous production of ATP from the mitochondrial respiratory chain. So mitochondrial respiratory capacity of the sperm has been analyzed by oxygraphic approach in order to definitely provide evidence of a specific activity of MYOINOSITOL in ameliorating oxophos in human sperm. Ionositol able to improve the sperm mitochondrial function, thereby improving the sperm motility in patient with altered sperm parameter. Hence, patient with idiopathic infertility could take advantage of AMO suspension. In azoospermia, the medical condition, a man's semen contains no sperm or viable sperm. It can be classified into 3 categories: pre-testicular, testicular, and are known as non-obstructive azoospermia, whereas post-testicular azoospermia is considered as obstructive. It is already evident that calcium ion oscillation may be important for cells' basic function, that is the differentiation, metabolism, and proliferation, survival, growth, and multiplication. Here is the role of violation comes into the effect. MYOINOSITOL serves as a precursor synthesis of the ionoacetyl triphosphate. It should be mentioned that depletion of the IP3 can lead to improper calcium oscillation, which results in abnormal production of the sperm. Therefore, supplementation with MYOINOSITOL can avoid IP3 depletion and enhances the intracellular calcium oscillation. Actually in sperm count, where there is azoospermia found, if it is not the surgical cause, whether for post-testicular obstruction, then if testis, either it is from the pre-testicular or testicular azoospermia, it is also, MYOINOSITOL also has the effect on, some effect on azoospermia. Capacitization, hypermotility, chemostaxis, acrosomal reactions depends on the calcium ion oscillation, and the fundamental level of the MYOINOSITOL acts directly on the mitochondria, increasing the membrane potential. MMP is an apotopic marker clearly related to the functional parameters of the sperm cell, including motility, the capacity of fertilization, and embryo quality. High values of MMP indicate that the integrity of the structure with optimal levels of the activity are associated with high cell viability. Research studies suggest that MI has a significant role in increasing the sperm motility and increasing the MMP, probably increasing the cytoplasmic calcium and consequently inner mitochondrial calcium. Effect of on the sperm quality in men with metabolic syndrome, concentration before and after given, data is given. The impact of in vitro semen supplementation with MYOINOSITOL upon DNA fragmentation was addressed in a cross-sectional study done in men and presented at 250 nation meeting. Although the preliminary report a significant overall decrease in the DNA fragmentation was determined in MYOINOSITOL tested sperm, it is not expanded to a larger group. And thank you very much for this patient hearing to all our colleagues.
Thank you very much, sir, for this nice presentation. Just give me 1 minute time, sir, to check whether any question is there. Sir, one question is, sir, what are the diagnostic tests used to perform for a diagnosis of this male infertility? Preliminary diagnostic tests.
Preliminary diagnostic test?
Yes, sir.
Male infertility. Actually, male infertility, if the semen parameters are normal, then it is very difficult to diagnose whether the male is all the parameters, including the motility and everything, the morphology, motility, then it is very difficult to diagnose that male is contributing to this infertility.
Thank you, sir. And sir, another question is, how long this MYOINOSITOL can be given to get the successful outcome in the sperm parameters?
MYOINOSITOL, actually, it is a very initial stage. Actually, I have not started. So in PCOD, what we are given, it is continuously we are giving for 2 to 3 months. MYOINOSITOL and chorioionositol combination drugs we can try if we don't find any cause for male infertility, idiopathic male infertility, and can check semen analysis for whether there is any improvement or not. It is no, there is no definite, actually you should start for first 3 months, you can safely can give. Actually, MYOINOSITOL can be given in higher doses and for a longer time.
Thank you. Thank you very much, sir. So thank you very much, sir. I could not find any other question right now.
Okay.
So once again, sir, thank you for your valuable time in our platform, and in future also we look forward for some valuable session in some valuable topic. So thank you very much, sir. Have a good day, sir.
Thank you.